All right, so here's my presentation on heart failure. So before we actually get into the pathophysiology of heart failure, I kind of want to review over these 4 key points, which would be cardiac blood flow, cardiac output, ejection fraction, and cardiac muscle dysfunction. So first is blood flow through the heart. So tissues in need take oxygenated blood and take the oxygen out, turn it deoxygenated. That deoxygenated blood enters the heart via the great cardiac veins, superior vena cava and inferior vena cava, entering into the right atrium, passing through the right AV valve into the right ventricle, pumping out through the pulmonary valve, into the pulmonary arteries where it goes to the lungs, comes back to the heart with oxygenated blood via the pulmonary veins, entering the left atrium, the left AV valve, left ventricle, aortic arch, and the coronary arteries. It's cardiac output, which is the volume of blood pumped out of the heart each minute. Stroke volume is the volume of blood pumped from the left ventricle per heartbeat. And cardiac output is stroke volume times heart rate. On the image here, we can see some factors affecting heart rate and some factors affecting stroke volume. Ejection fraction we're familiar with. Fraction of blood ejected from the left ventricle each heartbeat. There's end diastolic volume and end systolic volume. So stroke volume is end diastolic minus end systolic. The ejection fraction equation is stroke volume over end diastolic volume times 100. So stroke volume is how much blood is leaving per beat. End diastolic volume is basically how much is left over at the end of diastolic filling. And the ejection fraction is just the percentage of blood leaving versus how much blood is actually there. And this will come in handy later when we're talking about differences in ejection fraction in systolic versus diastolic heart failure. And then cardiac muscle dysfunction. So this is kind of a general concept that we're going to have to come back to time and time again throughout this. So in general, cardiomyopathy is a disease in which the contraction and relaxation of myocardial muscle fibers are impaired. Cardiac muscle cells will either adapt or die to meet these demands. So a decreased cardiac output, the body changes to increase work, whether this is we need more stroke volume to increase cardiac output, or we need to increase heart rate, or whatever mechanism. Because of that increased work on the tissues, there's an increased need for oxygen. Cells will either die or adapt. So if they die, you might see something like dilated cardiomyopathy, or if they adapt, you might see something like hypertrophic cardiomyopathy. And we'll dig into this a little bit more as we talk about the different types of heart failure. First one we want to talk about is systolic heart failure. So to put it simply, it's an insufficient force to pump blood during systole. This presents as a thin and weakened muscle in the ventricles, as seen by this photo here, which we referred to earlier as dilated cardiomyopathy. This is caused by underlying diseases or causes such as like cardiomyopathy, coronary artery disease, valve disorders. So when we think about dilated cardiomyopathy, this involves thinning of the muscle walls and death of cardiac muscle cells, resulting in less force production to pump blood where it needs to go or during systole. We can get reduced blood flow to the heart or coronary artery disease. So this is a buildup of plaque in the lining of the coronary arteries, which supplies blood for the muscles of the heart. The heart is always going to be working. Work requires oxygen. Oxygen requires a good blood supply. So without the muscle cells, without a good blood supply and oxygen supply, the muscle cells are going to die and the heart will become weaker. And as a result, the walls will become thinner and look something like this. Then we have valve disorders. So we can have regurgitation, which is blood being pumped by the ventricles backflows into partially open valves. Less blood goes to where it needs to go because stroke volume is going to decrease. When less blood goes to where it needs to go, there's less oxygen to tissues that need it. That's where you get cell death, and then you kind of get into this loop of, weaker cells, cell death, thinner walls of the heart, less stroke volume. Then we have stenosis, and that's just a narrowing of the arteries exiting the heart, therefore increasing resistance, or the force needed to push blood through that smaller diameter. Increased demand, kind of like what we're seeing, increased work of the heart's muscle cells. They need more oxygen. Obviously, stroke volume doesn't go up significantly enough, so that need for oxygen isn't met. Then we're met with more cell death, and then we have a weaker heart with thinner walls. So, and then there's arrhythmia, which is heart pumping too fast or too slow in an uncoordinated manner, leading to a reduced pumping ability because you might not have total filling and you might not have the systole occurring when it needs to happen to get the most stroke volume. So kind of like that same loop, we have an underlying issue. This leads to poor cardiac output. we have less oxygen present for the tissues that need it, and then those cells die and muscles thin, and you're left with an enlarged heart, but with really thin myocardium, especially on the ventricles. And then one of the ways this is diagnosed is via ejection fraction. So you take the total volume that the ventricle can carry, and then the stroke volume, or like how much is leaving. And this is measured with imaging, I believe, an electrocardiogram. And generally we're looking for a number between or above 50% ejection fraction. Although when we talk about diastolic heart failure, this isn't exactly going to be the case. So diastolic heart failure, it's a failure of the heart to adequately fill with enough blood. So that diastole, that relaxation. Less filling means we get less leaving each beat, so you get less oxygen transport in general. This is going to present as thickened walls of the ventricles due to hypertrophy or cell death of cardiac muscle. So it can be a mix of the two. And this is caused by underlying conditions, so we can have chronic hypertension, so increased pressure of the arteries, resist blood flow leaving the heart. Increased pressure means more work. More work in this case means adaptation via either hypertrophy or kind of like what we see with systolic heart failure, where you see that cell death. But in this case, the cell death is going to create a stiffening in those dead cells, and almost like what seems like a scar tissue buildup in that left ventricle. We have aortic stenosis, which is increased resistance to blood flow leaving the heart due to narrowing of arterial walls. We kind of just talked about this. We get increased resistance, so poor cardiac output, less oxygen present, you either get cell death or compensation. And then both of those kind of cycle into poor cardiac output. General cardiomyopathy, in this case, it looks either hypertrophic or restrictive. So in hypertrophic cardiomyopathy, we're kind of met with this, where we have an increase in cardiac muscle cells and growth that reduces end diastolic volume. So these are the same numbers from the previous slide, but end diastolic volume would actually be much lower. So in reality, this total volume would be about 70 milliliters, but then the ejection fraction would appear to be normal. So you're like, well, that's not right. But that's just because the chambers of the heart can't fill adequately because the muscles grow in hypertrophy, and they can't actually fill adequately. And because they can't fill enough, they can't pump enough blood to where it needs to go. So then you're left with this poor cardiac output and this ever building cycle. And then we have restrictive cardiomyopathy, which is an increase in cardiac muscle cell death and stiffening, reducing contractility of the heart, and therefore reducing end diastolic volume. Because when the heart pumps, blood comes in, and there's kind of like a stretch shortening cycle that allows it to pump as hard and efficiently as it does in a healthy heart. But with this cell death, you actually get some degree of stiffening in combination with the hypertrophy. So hypertrophy decreases our volume, cell death decreases our contractility. Underlying issue creates poor cardiac output, lacks oxygen present. Two routes to go here, either cell death, further increasing poor cardiac output, or compensation, which leads to hypertrophy, which also gives us our poor cardiac output. And we're kind of left in this infinite loop here. Now we're going to talk about left versus right heart failure. So our right side of the heart, this is going to be a failure to pump enough blood, deoxygenated blood out of the right ventricle to the lungs. So we've got two main types here. This forward failure, which is less oxygen and more carbon dioxide present in the blood. When you talk about forward failure, it's basically think about where the blood is going. So from the right side of the heart, we can't get, my bad, let me go back here. We can't get enough deoxygenated blood out of the right ventricle into the lungs, so that we're getting less oxygen in total because not enough blood is going to the lungs. Or we could have backward failure, so you'll kind of be met with this backlog of blood into body tissues, and you'll actually get congestion. On left-sided failure, this is a failure to pump enough oxygenated blood out of the left ventricle to the rest of the body, resulting in poor blood supply and oxygen supply to the rest of the body. So forward failure, in this case, is going to look like poor oxygen supply. How that would present would be obviously fatigue, because you're not getting enough oxygen to body tissues. You're going to have decreased urine production, and you're going to have a rapid or an irregular heartbeat. And if we get into like why this is, so if we go back to right-sided heart failure, why are we feeling fatigue in both of these cases? Well, fatigue in right-sided heart failure is due to less oxygen and more carbon dioxide present in the blood. So kind of like if you had like increased altitude, you're not getting enough oxygen. Similar, you're gonna have increased level of fatigue. And heart palpitations is more of a heart's attempt to compensate for reduced oxygen supply. And on right-sided backwards failure is your congestion, so your increased fluid buildup in the body, usually in distal extremities, but you'll also see increased jugular venous pressure as a result, because you're getting this backlog, right? So that you're getting tissue from the body and not going out to the lungs enough, so you get this kind of backlog of blood, and that's going to go up back through the venous system as well, and detectable via JVP. And our increased urine production is secondary as a result. You normally will see this at nighttime. So when supine, fluid in the body that would have been backed up is taken back into the bloodstream, and then blood is filtered by the kidneys to be eliminated as urine. So as this blood kind of fills up in body tissues, when you get supine and you lay there for a while, it gets reabsorbed, and then your kidneys try to filter out what it would, so then you have that increased urine production. So back to the left side. On the left side, we have fatigue. This is due to tissues of the body still being deprived of oxygen. We'll actually see decreased urine production. This is because the body isn't receiving enough fluid from the blood, because we have this fluid backup in terms of pulmonary congestion in most cases. And we'll have a rapid or irregular heartbeat. So what this looks like is palpitations as an attempt to compensate, just because there's not enough oxygen going to tissues. So that would be like a sympathetic nervous system compensation. And then we have backward failure. So we have difficulty breathing. This is because fluid is backed up into the lungs, and alveoli are filled with fluid rather than air. So you might see an increased respiratory rate, or you might just see like general signs of compensatory breathing where they're not, doing diaphragmatic breathing. They might be like tripoding, or they might be breathing with their accessory muscles. You'll also see productive coughing. This is an effort to clear alveoli of fluid, which appears pink in color because there's some blood left over from that backflow and that pulmonary congestion. And this is going to be significantly worse when at night and lying down, because the blood will instead of being seated towards the bottom of the lungs as like for gravity, you're going to lay down and it's going to spread, and it's going to set off those irritant receptors and those cough receptors and make you cough. And then we'll have weight gain. So there's going to be increased fluid retention because of that decreased urine production. So you'll actually see weight gain as a result. And it would be unexplained weight gain. It'd be like more than 10 pounds in, I think, less than 2 weeks. Now we'll go to progression. So what this looks like is there's a few different ways. There's sympathetic nervous system activation. This is an attempt to increase our cardiac output by contracting the ventricles harder and at a faster rate. So basically trying to increase our contractility by doing harder, and heart rate to increase our cardiac output. So more contractility, more stroke volume, more cardiac output. You can kind of see by this chart here. But over time, this leads to receptor overuse and downregulation of the heart's beta receptors. So this isn't like a lasting thing, and it won't. Left untreated, factors will worsen over time. We'll kind of come back to this statement with each of these. And then we have renal activation, which would be like trying to increase preload. So increase ventricular filling via aldosterone and ADH release, or antidiuretic hormone, increases the pressure and volume of the blood leaving the heart, but this requires more work, which needs more oxygen, which when not met will cause cell death over time. So you can kind of see these mechanisms: increased antidiuretic hormone, we're going to urinate less, we're going to get more circulating volume, so we have more venous return and thus more preload, which should increase stroke volume, which should increase our cardiac output. And then we have myocardial hypertrophy, which we kind of already talked about with diastolic heart failure, but the heart is gaining cardiac muscle to try to increase stroke volume via force output to meet that decreased cardiac output demand. But this reduces the space available for the blood to fill, so your total stroke volume actually goes down as your end diastolic volume goes down, or the amount of space the heart can actually fill goes down. And all of these things won't be like a permanent change to increase cardiac output. Left untreated, they will get worse over time. So the progression is pretty, I wouldn't say linear, but definitely like it's hard to go a step back, especially when some of these things occur, like structural changes to the heart. Renal activation is a little more modifiable, but sympathetic nervous system activation instead. But like once there's actual structural changes to the heart, it's really difficult to go back from that. So when we actually go through diagnostics, there's our echocardiogram, which is how we would kind of look at our ejection fraction. It measures the pumping ability of the heart and lets you see it. A chest x-ray, so we can kind of see these two sides here. On this one, we can kind of see some pulmonary congestion. You can see these little white wisps, this radio opaque signs here. This kind of tells us there's fluid in the lungs. And then we see how big the heart is. It's reaching really far over here into the lung. And you're looking for like a kind of like I just highlighted, enlargement of the heart or like fluid buildup in the lungs. And then we've got our blood testing. So we have B-type natriuretic peptide. These are the values as per the APTA guidelines. In general, less than 100 is considered normal. 100 to 300 would suggest heart failure. 300 to 900 would be considered mild to moderate heart failure. And above 900 is considered severe heart failure. But what is B-type natriuretic peptide, or BNP? It's secreted by cardiac muscle in response to stretch. So that's how it can be used to detect systolic heart failure, but not diastolic heart failure. Then we've got a couple classification systems. So we have the New York Heart Association, which is measured via like stress test. So there's class 1, no limitation in activity, and no symptoms at rest or with activity. Class 2 would be no symptoms at rest, but some with activity. 3 would be no symptoms at rest, but increased symptoms with activity. And class 4 would be increased symptoms at rest and severe symptoms with activity. And then we have American Heart Association, so there's stage A. You'd be considered at risk. This is risk factors are present, such as increased blood pressure, diabetes mellitus, and you see no symptoms or structural changes to the heart. In stage B, it's considered pre-heart failure. You have no symptoms still, similar to stage A, but there are structural changes to the heart present, so that kind of changes the way you approach it. There's stage C, which presents with symptoms and structural changes to the heart, and then there's stage D, which is presenting with more advanced structural changes to the heart and an increased symptoms and possibly symptoms with rest. Here's how it's kind of managed in terms of early, middle, and late. So in our early phase, our risk factors are present. You have hypertension, you have coronary artery disease, you have diabetes mellitus, and generally patients are asymptomatic. So our goal is to improve these risk factors. The way we do this is through exercise with the intention of increasing heart efficiency and increase the heart's ability to pump blood and increase cardiac output. We've got some dietary changes. This would look like decreased salt intake to reduce blood pressure and reduce compensation and likelihood of structural changes. Then we have medications. So we have our ACE inhibitors. So they're vasodilators that are going to decrease our blood pressure. We have hydralazine, which is going to act on arteries to decrease our blood pressure. Nitrates act on veins to decrease our preload. And then our beta blockers, which are going to inhibit the sympathetic nervous system, decrease our heart rate, and decrease our pumping force. These will tend to have the most side effects. And then we have our late stage treatment. This is when they have symptomatics and they do have structural changes. So our symptoms are going to be congestion and fatigue. So our goals kind of shift from not only improving risk factors, but also improving risk factors and decreasing symptoms. So exercise, the goal is exactly the same: increase cardiac output and cardiac efficiency. Dietary changes are the same: reduce sodium intake in an effort to decrease the amount of strain on the heart by lowering blood pressure. And then you have medications. So we've got diuretics in this case because we have congestion. Diuretics are going to remove excess fluid because they're inhibiting aldosterone, and thereby decrease blood pressure because we have less fluid in general. We have calcium channel blockers, which is going to cause the arteries to dilate. This calcium is needed by smooth muscle to constrict arteries, so blood pressure will reduce as a result. Heart rate is lowered as well, allowing for more time for ventricular filling. And then we have digoxin, which will increase contraction strength of the heart and decrease heart rate. And then we have our ACE inhibitors and our beta blockers. Then we get to some devices and surgery, more utilized in late stage. So first we have a ventricular assist device. Here's a picture of what one looks like. This is a left ventricular assist device, and we talked about this a little bit in class, where there's a wire that will leave the body, and there's a system controller and a power source, sometimes two power sources. And you can have it on the right side, the left side, or sometimes both. It would be referred to as a BIVAD. And basically what this does is it assists the ventricles in pumping blood to the body, connected to a battery on the outside, and it's generally used for patients waiting for surgery or cannot undergo surgery, but their ventricles still need to produce that high enough cardiac output to keep them going. Then we have a pacemaker defibrillator, also referred to as cardiac resynchronization therapy. So they could be pacemaker with or without a defibrillator. It would be attached to the heart with leads and ensures that the ventricles pump forcefully and in unison. A defibrillator can reset rapid heart rate to a normal rhythm, given that it's a shockable rhythm. So if they go into asystole, I don't believe that's a shockable rhythm. I don't think you can get them back from that. But there's different types of arrhythmias that you can that are considered shockable rhythms. And don't touch the patient if they're about to defib. And then there's surgical interventions. So we have stents, which is a device that's put up in the arteries to reduce resistance and pressure and allow for easier blood pumping. So think of it as a widening of that artery or that canal, putting in almost, I want to say like a spring of sorts that just widens that passage so that we have decreased resistance in general. We have a coronary artery bypass, and it's going to reroute blood flow around a blockage via grafting from a donor site, which is usually the femoral vein or artery. And then we have the complete heart transplant, which is a kind of like the Hail Mary. It's an end-stage heart failure intervention used for patients as a last resort when all other interventions have failed. So here's our kind of pictures here. Here's kind of a rehash of how heart failure is managed. So stage A, B, C, and D. This is early, no structural changes and no symptoms. Kind of outlines the goals here. Discourage alcohol intake or drug use. Here's the drugs that might be used. Treating hypertension, encourage smoking cessation, lifestyle habits. Here's kind of some of the things we might see with it. Oops. And then we see stage B, where we do have structural heart changes, but no actual symptoms yet. The approach remains pretty much the same. But then as we get to stage C and stage D, we see a little bit more differences in the way we actually treat in terms of drug selection and device selection, especially. And then you'll start seeing them having symptoms like shortness of breath, fatigue, poor exercise tolerance. And then stage D is just an increased amount of those problems. So mark symptoms at rest and at max, kind of like we talked about before. And then you're definitely into surgery at this point. May have had surgery before, probably had a bypass or a defib at this point. So that's it. Here's the references here. Thanks for checking it out.